Welcome. My name is Yanan Silas Bosan. I'm the Assistant Manager, Clinical Services at Cedarcrest Hospitals. This is the first of a CSR initiative that we would like to continue to do. The talk is being given by our Group Medical Director, who is an orthopedic surgeon, Dr. Kingsley Ekwe. So he'll just go through the basics of low back pain, and I would ask that if you are not speaking, which is during the presentation time, that you mute your mic, and that if you have any questions during, you can type them in the side chat bar on the side, and that wherever you can send your questions directly to me, to the speaker, Dr. Ekwe, or to everyone, whatever makes you feel more comfortable. But I'll hand over to him right now, and thank you all for joining us.
You're welcome.
Good morning, everybody. You're welcome to this. This is our first webinar, Cedarcrest webinar. Many hospitals do webinars, and most of them focus on doctors, but we decided that we're going to do at least 50% of our webinars to focus on our patients, especially for patient education and things like that. So today we're going to be talking about low back pain. It's going to take about 25 to 30 minutes, and then hopefully we'll have enough time to take the questions at the end. So I'll start. Okay, can you all see my screen?
Yes.
All right, so low back pain is quite common. It's actually said that 80% of people who are alive will have back pain, some sort of back pain at some point in their lives. And most of our patients who come to orthopedic clinics, more than 50% of them actually present because of back pain. There are three types of back pain for us: what we call acute back pain, less than 4 weeks duration. Chronic back pain is 3 months at least duration. And in between is what we call subacute, which is not a very well-defined subset of people who have back pain for longer than a month. But the most common types of back pain that come to hospital are chronic low back pain. And I will try to define what the different terms are, because many times there is a gap in communication between the doctor and the patient when it comes to what back pain is. So the back, what we call the back, is the rear surface of the human body from the shoulder to the hips. The hips are the widest region around the pelvis. That's around the buttock area. That's what we call the hip. And the waist is the halfway between the hips and the chest. So, I mean, when I was younger, I used to say that the waist was the narrowest portion between the hips and the chest. But of course, now I've grown older, even for me, it's not necessarily the narrowest, but at least it's halfway between the hip and the chest. Now, the commonest areas related to pain in the spine, and I'll define what spine is later, are the neck and the lower back. Today, we're not talking about neck pain. That will probably be another session, but we're talking about low back pain. And the reason why they suffer pain more is because they are subjected to movements, and then because of that, they suffer wear and tear. Now, if you can see this picture, the area is called the bust line, where I'm showing now. That's around the breast, and that's where I refer to as the chest. So the waist, like I said, if you probably still have your figure 8, is the narrowest portion. But let's say it's halfway between where we call the hip and the bust line and the chest. So you can see that. So when patients talk about waist pain, the waist is not just where a lot of the pain is concentrated in the lower back. The waist is all the way around to the sides and all that. So many times you tell a doctor that you have waist pain, and the doctor will say you have low back pain. We're probably just trying to play doctor and be exact. I'm sure we know what you're talking about, and we know you know what we are talking about. So it's the same thing that most patients will refer to as waist pain. Now, when we call the spine is another name for calling the backbone. Now, the backbone, incidentally, does not refer to one bone. It's actually 31 bones that are arranged in a stack from the base of the skull around the upper neck region to the buttock region. And there are 5 different types of bones that make this up. The bones around the neck are called the cervical vertebra, and the ones around the chest are called the thoracic vertebra. There are 7 cervical and there are 12 thoracic. The ones around the lower back where we're discussing are called the lumbar vertebra. You can see that they all have different outlines. Then the ones in the pelvic and buttock region are referred to as the sacrum and coccyx. They are fused and they hardly cause any problems at all, except the problems that they can cause. But most of the problems are concentrated around these 5 lumbar vertebrae in the lower back and the 7 cervical vertebrae in the neck, because, like I said, they are subjected to wear and tear because of frequent movements. Now, in between each set of bones is a disc. The disc is a soft material that is like a shock absorber, and its job is to prevent bone from rubbing against bone. But then, because of that frequent movement that can occur, the disc can undergo wear and tear and can begin to shift from where it is and to cause pressures around all the things around it. The most important function of the spine, the 2 most important functions of the spine are, one is to give our body shape, because it's what gives us our upright shape. Without the spine, you will just collapse like a mass of flesh. And the second function, you can see that all the bones have holes in them, and when they are stacked together, they form a tunnel or a gutter that the spinal cord passes through. So the second most important function is to house the spinal cord, and from each of these holes, nerves come out that take instructions from the spinal cord to different parts of your body. That's why you're able to move your legs or your hands and all that. So those are the important reasons why the back pain come in different dimensions, because there are many things, important structures around the spine. Now, this is just the skeleton, of course. It's now covered by muscles, ligaments, and other things that can also cause pain. So you can see that the cervical vertebra around the neck, thoracic vertebra around the chest, the lumbar vertebra and the lower back region of the waist region. And then the buttocks area contain the sacrum and the coccyx, which, like I said, because they are fused and they hardly move, they hardly cause problems. So what are the common causes of low back pain? The commonest cause of low back pain is what we call non-specific low back pain. It's not, you can't really tie it to anything specifically. Sometimes it's muscle spasm, sometimes it's a mechanical pain, sometimes it's probably stretching or overwork of the spine. If you do an X-ray or an MRI, you won't find anything wrong. And so forth. And then many of the times, this pain doesn't last for long. It usually lasts for a few days or a few weeks and then disappears. But that's a really important cause. Sorry, the commonest cause of low back pain. Then you have degenerative disc disease. Degenerative in the sense that with aging, wear and tear will happen. And the disc, because the disc is like a shock absorber, it bears the brunt of this wear and tear. This is usually related to age or activity, and it affects the disc. You can have what we call a slipped disc or a prolapsed disc, which is quite common. People have experienced that. That's when the disc begins to push out of its space and either push onto the spinal cord or push onto the nerves or push onto something else that it's not supposed to push onto and cause pain. You can have arthritis or some of the joints of the spine. The facet joint is the most important one, and that can also cause pain. Now, this is a long name, spondylolisthesis. It's tongue twisting, but what it means is that the vertebrae are stacked, like I said, one on top of the other, but they are arranged in a neat line. Sometimes, because of different reasons, one vertebra might begin to move relative to the other, so they are no longer arranged in step. And when it begins to move, it begins to pull the spinal cord and the nerves out of position, and that can cause pain. That's what is called spondylolisthesis. Now, canal stenosis is where, because of different reasons, the space where the spinal cord is supposed to be in is narrowed. And when the spinal cord is narrowed, there's only a certain amount of narrowing that it can tolerate. After that, the spinal cord function begins to be affected. So that's called spinal canal stenosis. Occupational back pain is like a longer term version of the non-specific back pain. So heavy lifting, frequent lifting, poor sitting posture, those things can cause back pain in some patients. There are some causes of back pain that are quite serious, and I will make references to them later. Some of them can be emergencies. Cancer is one of them. It's not common, but cancer tends to spread to the bone, and the bones of the spine of the lower back are actually one of the culprits that you can have, especially with breast cancer and prostate cancer, and that can cause pain. Infection can have acute infections like bacterial infections or tuberculosis of the spine, which used to be quite common, but it's no longer as common, thankfully. That can also cause pain. You can have vertebral fractures. In other words, the bones of the back can break. The commonest reason why they break will be an accident. But even in patients who have not had an accident, especially in elderly patients, especially elderly women, because the bones can be soft, you can actually have the bones breaking without much trauma, maybe just even sitting heavily or something, because these are repetitive injuries. And then what we call caudal equina syndrome. This is a situation where the spinal cord is being compressed to the extent that it begins to affect the function, and is considered to be urgent and serious because it can lead to paralysis if it is ignored. So what do patients feel? What do patients come with? So the patient will come and tell you that, oh, I have waist pain. So most of the time, the doctor will try to ascertain what kind of pain it is by asking a few questions. And after asking a few questions, the pattern becomes obvious to the doctor. And if it's an acute pain, in which case the pain just a few days, it's not happened before, it's different. If it's a chronic or recurrent pain, in which case the pain has happened for a few months or a few years and goes and comes, you know that, okay, this is a chronic pain, and this is probably something that is not going to go away easily. And then you now begin to ask the patient more questions. So their pain the commonest kind of pain is the disc pain, what we call discogenic pain. This pain gets worse when the patient bends forward and improves when the patient stands up or lies down, because the spine is straightened up. Sometimes the pain may go down to the buttocks of the thigh, but the main pain is in the back. Now, that's different from the pain, which is more in the going down the buttock or the thigh or the leg, usually one side, and they may have back pain or may only have mild back pain. This one is what you usually refer to as sciatica or radiculopathy. It can be caused by the same thing, but it's the different pattern of pain because you attack them differently. There are some patients, a few patients, where the back pain gets better when they bend forward. So that's the opposite of a disc pain. But when they stand up straight or when they lie down, the pain gets worse, especially when they stand. That's due to osteoarthritis of the spine. There are some kinds of patients who may not even have back pain at all. The pain in the leg might not be much unless the patient is walking, and usually affects both legs. As they walk more and more, the pain becomes worse, and they need to squat or sit down for the pain to improve. And after some time, when they sit down for some time, the pain just disappears completely. And when they get up and start walking again, the same cycle repeats itself. If such patients get into hospital, they realize that the distance that they can walk before they become uncomfortable will keep reducing because that gets worse. That's caused by spinal stenosis, and that's called spinal stenosis. So the doctor will try to see the pain. There are some that don't really fit into patterns like that, like the non-specific back pain, like I said, pain in the back, maybe cramping. They happen when they do something. You can also have the serious pain, but usually not debilitating. It doesn't stop them from doing most of the things that they can do. And most of these patients will improve with rest or with medication. Now, patients with infection or cancer have an unrelenting pain. In other words, changing position does not stop the pain. Whether they lie down, whether they stand up, whether they sit down, doesn't stop the pain. And the pain can be worse at night. Some of them may, the patients with this kind of pain tend to have a serious pain. And these are the kind of patients encouraged to come to hospital. Patients who have fractures have severe pain that starts suddenly because the bone might be getting softer and softer, but it cracks at one time. And from the moment it cracks, the pain is quite severe. But the interesting thing about this pain is that every movement increases the pain. You cough, the pain is worse. You move, the pain is worse. Every movement increases the pain. And there are other things that can cause this, but a fracture is one of them if the patient fits the profile of somebody who whose bones have become quite soft. So when is the patient encouraged to go to hospital? So when the pain is severe, and severity might differ from patient to patient, depends on your tolerance to pain. But when the pain is severe or when it's serious, you should stop in hospital. When the pain is more than 4 weeks, because like I said, most of the specific back pain will improve. Either you take paracetamol, rest your back, most of it will improve. So when the pain is getting longer than a month, so when the pain is unrelenting or worse at night, like I said, it could be an infection or a fracture. When the patient is losing weight, not intended weight loss. Of course, sometimes you can be planning to lose weight, you're dieting or you're exercising or something, but this is an unintentional weight loss associated with back pain that has been going on for some time. That you shouldn't sit at home, even if you can cope with that kind of pain. When the pain is going down to the buttock or thigh or leg, it's a sign that the disc is out of position and is probably putting pressure on the nerve. If you're having to squat or sit down to be able to continue walking for a reasonable distance, that's an indication for you to go to hospital. There are some things we call red flags. Red flags mean that this is a sign of a danger sign. It's a sign that something serious is going on and might get worse if you don't intervene on time. One of them is unrelenting pain. So pain does not get better with any position. Whatever you do, the pain is just the same. Usually at night when you should actually be having some relief, that's when the pain can even be worse. That kind of pain should not be kept at home and usually will mean something serious. If a patient is not able to pee or if a patient cannot hold the urine, that's an indication that the spinal cord function is being affected to a great degree. And usually we call that a red flag. When every movement is painful, that's sometimes, and the pain usually starts suddenly. That's usually a sign of a fracture. If the patient has weakness or heaviness of one leg or the other, or both legs, that's not a good sign. And then when a patient is losing weight, and if any of these red flags is noticed, then it is even more urgent and more imperative that the patient shows up in the hospital. So what would the doctor do when you come to hospital? Usually we would ask you some questions. Like I said, he will try to determine the pattern of pain you're having. It helps him to channel his mind towards where the pain is coming from. He might do some examinations. Sometimes if the doctor doesn't think the pain is that serious, he might just ask you to rest your back, do some massages, give you a few drugs and go. Sometimes we request for x-rays. Many times the x-rays are just to give us a baseline or to rule out more serious things like sometimes cancer and things like that. You can just see them, tuberculosis. You can see evidence that may make you ask for more things. If you really want to see more, then you need to do an MRI. Because an MRI is expensive, we don't always ask for it, especially if it's not going to change the way we manage the patient. But if we're suspecting that something might be going wrong, we will ask for an MRI, because an MRI can show you more than an X-ray can. X-ray will show you the bones and the way they're arranged, but MRI will show you the disc, the spinal cord, the nerves, and other things. So you might see a sign of an infection or something. If you're suspecting a fracture, a CT scan is probably your best bet for seeing what you're looking for. Some blood tests may be necessary to show evidence of other things going on, like infection and cancer. There's a machine called a DEXA scan. It's not very commonly available, but we have one here in Cedarcrest. It shows you the strength of the bone. So when you're suspecting that the bone is becoming so soft that it might be a reason why the patient might be having pain, or the patient might be prone to a fracture, you can do a DEXA scan just to show and confirm how soft the bone has become. So after the doctor finishes doing all the tests, what would he do? Usually, if you're very uncomfortable, he may give you drugs, ask you to rest, maybe give you an excuse duty so that you're free from work if your work is very tasking, and just ask you to rest a bit. If you have red flags, you will not be allowed to go home because these are potentially serious things. So if you have any red flag, it means that you're at risk of a paralysis or something sinister going on. So they might need to intervene urgently. So usually most doctors will not give you a chance to go home. So that's when intervention might be urgent or even an emergency, like in infections or fractures or caudal equinal syndrome. I'll talk about that later. In other situations, most of the time, doctors would ask you to go home with analgesics or go home even without analgesics if you're comfortable, and come back when all the results are in, MRI and all your lab tests are in, so that we know exactly what we're doing before we proceed with your treatment. For acute back pain, most of the time patients will rest, and the rest should not be prolonged. In the past, for those of you who are old enough to be aware of things around the hospital in the 90s or the 80s, once a patient has serious back pain, you come to the hospital, they'll put you on traction, they'll tie your legs and hook you up to the bed for about 6 weeks. That used to be very trying. And even though it had its benefits, we realized that the disadvantages were more because it made the back muscles very weak. And while your pain went away immediately, it tended to come back and more seriously. So I'm not sure you will see a lot of people doing traction now for back pain. Medications are common. We give painkillers and muscle relaxants as part of acute back pain. Hot water bottles, heat therapy, physiotherapy. We can ask patients to modify their walk, especially if their work involves prolonged sitting. So for chronic back pain, now these are the more serious back pain. There are 3 levels of treatment. And the first level of treatment is what we call conservative management, where you're not doing any intervention or and this is hinged on 4 legs. One leg is physiotherapy, which is probably the most important leg. There are many modalities that the physiotherapists depend on, and sometimes they will strengthen the muscles of your back or do some back manipulation or something that will relieve you of the pain. Now, the importance of physio is that you don't want the patient to become dependent on medication. So as you try to teach them ways for them to cope with the physical demands that their back is undergoing, that will tend to be the more long-term treatment, so that even if painkillers and muscle relaxants work in the short term, the physiotherapy will help to prolong the benefits that they get from the treatment. For patients who are in serious pain, you can ask them for bed rest for a while. Now, this bed rest usually will just say, don't leave the house if you can, or just take short walks outside of the house. But we no longer ask you to just rest in bed strictly, because like I said, we also don't want the muscles of the back to get lazy because that tends to have its own effect later. So get up, do regular everyday things around the house. The 4th leg is lifestyle modifications. I'm going to talk about some of this later when I'm talking about prevention, so let me not duplicate it. The second type of treatment that patients get, especially when conservative management is not working, is spine injections. Now, injections are peculiar because they are not meant to cure the patient. But it can give you long-term relief, sometimes 6 months, sometimes up to 24 months. And patients tend to like that because the injections, even though it involves going to theater, but usually go home the same day. There's usually not much involved, and it's not as expensive as surgery and not as scary because nobody's cutting you open and all that. Now, not everybody benefits from injections. So if you select your patients properly, the patients might probably get more benefit from it. You may also give injections when patients are waiting for surgery. Either they're trying to gather money, or they're trying to make up their minds, or they're trying to ready themselves, or they're trying to tidy their work schedule so that they can have the time to be able to go for surgery. So injections are like midway between surgery and conservative management. But like I said, most of the patients do well on conservative management. Therefore, only a few patients will proceed to need surgery. Surgery may become inevitable. Most spine surgeons will keep surgery as a last resort unless there are red flags. If there are red flags, you can't ask patients to go and do conservative management or things like that because there's a risk. That's why the red flag is there. So if a patient has pus in the back and the pus is expanding and putting pressure on the spinal cord, you need to go and evacuate that pus. If other modalities of treatment have failed, you've done conservative management, you've given an injection and the patient has failed, an injection. Injections can be repeated. So sometimes the patient benefits initially from an injection, and because it benefits so much, you'll say, oh, doctor, I want you to give me an injection again. There's no guarantee that the injection will work as well the second time because the disease process tends to be progressing, even if the injection has masked the pain. So the patient I gave injection 2 years ago, the disease is not the same now. So there's no guarantee that if I repeat the injection, it will last for another 2 years. So sometimes if a patient does injection somewhere abroad and then comes and you are doing the second injection, and sometimes the pain relief doesn't last as much, the patient will think that, oh, you didn't do the injection as well as they did it abroad, but it's not true. The disease tends to progress. So over time, injections tend to fail. That's the general pattern. So surgery might be done for the severity of the disease because of you don't want it to get worse, or to prevent a complication like paralysis, like I was saying, and usually a last resort. So those are things that we can verify. We are sure that work. The things we are not sure that work include a massage, except if it's for non-specific back pain, spasm, or cramp. But for chronic back pain, massage is probably just going to give you a temporary relief. Acupuncture is an alternative medical modality that has many people that like it and support it, but the pain relief tends to be temporary as well. And so this is probably not a long-term pain relief for chronic low back pain. Corsets and braces, we're not sure they work, but except in situations where the patient has an unstable spine, a brace or a corset is not very useful. But then there are many patients who tell you that, oh, when I wear my corset, I feel very good and all that. We don't know whether it's psychological or whatever, but we allow them wear it. You just don't want to wear it for so long or so consistently that the spine muscles become weak or lazy. So even for patients who wear corsets, we ask them to remove it sometimes so that the back muscles can have a chance to actually contract and maintain their integrity. Traction, like I said, is getting out of use. I can't remember the last time I saw a patient on traction because of back pain. Chiropractic is also alternative medical modality. We're not sure if it works. So who is vulnerable to low back pain? Remember that I said that 80% of people would have back pain at some point in their lives. So anybody can be vulnerable to low back pain. But there are some patients, either due to the kind of people they are or the kind of habits that they have adopted, that are specifically vulnerable. Smokers are one of them, for people who smoke heavily, especially. What happens is, as you grow older, the body undergoes wear and tear, even at a microscopic level. So the things that happen to the body as the body gets injured, the body has healing factors that it sends there to heal them. So there are many things that get injured and healed as you're going about your normal activities you are not even aware of, because the body has a way of taking care of them. So it's just almost like, oh, something has gone wrong with one cell in the back somewhere, and the body will just send repair factors to repair them. So there's always ongoing damage and repair as we're going about our daily lives. The repair factors are transported through the blood vessels. For people who smoke heavily, the blood vessels, instead of being flexible pipes, they become rigid and they become narrow. So it affects the blood flow, especially to narrow blood vessels and different parts of the body. So the ability of the body to repair what is being damaged as normal is affected. So the body is not able to repair as well. So we realize that for someone who smokes, even the normal wear and tear of the back that should take 5 years or 10 years to manifest will manifest earlier. So those patients will have back pain earlier. Obesity is another factor. The back is like the focal point of our body weight before it goes down to the legs. So for the bigger the patient, the more strain on the back. The sedentary lifestyle or back-breaking work. So these are two different extremes. For patients who have a lifestyle where they sit mostly in the office, they sit in the car, they get home, they sit in front of the TV. Most of the time they are sitting. This tends to make their back muscles very weak, and those patients are vulnerable to back pain. On the other hand, patients who do back-breaking work for prolonged periods, farmers and things like that, tend to have back pain worry them more. It seems like there's a genetic component to back pain. So it runs in some families, comes earlier in life, and it's a bit more serious in some people. When you ask, they will tell you that my mom also suffered from this, or my dad also suffered from this. We don't have a specific gene that we have isolated, but the pattern is unmistakable. It seems like back pain may run in families. Unfortunately, there's nothing anybody can do about this. The older you grow, the more vulnerable you are to having back pain, because like I said, it's cumulative wear and tear. It seems more common in females, especially some kinds of back pain. Let me not go into that. Work stress, job dissatisfaction, anxiety, and depression. Back pain is very common in people who are unhappy. Even if they had back pain before, the pain tends to get worse when they are not happy. So there's a psychological factor, some of it. So how do we prevent this? Obviously, if you cut down smoking or completely, that would be very good. If we lose some weight, especially for obese patients, the ideal body mass index should be like 25. Up to 30 is probably acceptable. It's not ideal. Some of those patients are what you technically call overweight, but it's still within context. But for patients who have a body mass index of over 30, then those are the kind of patients that you want to encourage to lose weight. It helps with the back. It doesn't only help with the back. It helps with the feeling more confident about yourself. It helps with knee arthritis. It helps with cholesterol and other diseases like diabetes and all that. Losing weight always helps for if the patient is overweight or obese. People who work at a desk should try to vary their position because that means you're going to spend quite a bit of time if you work an 8-hour job. If you sit 7 hours, or you sit most of the time, that's not very good. So it would be nice to vary your position. Instead of taking the lift, you take the stairs, you walk around. And when you're standing, try to put your foot on one block. That helps to ease the strain on the nerves in the back. Use proper chairs. I'm going to talk about proper chairs later. Ergonomic chairs, especially if your job involves a lot of sitting down. Use proper chairs. More importantly is to sit properly, because many people have proper chairs. Sometimes they'll come and they'll say, oh, doctor, write a letter to my office to buy me an ergonomic chair. And we write the letter, but then it's one thing to have the ergonomic chair, it's another thing to use it properly. And I'll talk about that later. If your job involves heavy lifting, then you need to think about the following. Preferably you do it when you're younger. Many jobs, say if you go to a site and you're working, you probably will see that many of the people who do the heavy lifting are much younger. So the hope is that maybe if you start heavy lifting when you're 18, by the time you are 30, you're becoming a supervisor or a foreman, and you're not doing most of the lifting yourself. Because the longer you do this, the more strain you're putting on your back. Don't do it for too long, and then learn to lift properly. Exercises are good. Walking, swimming, using a stationary cycle. Having a sedentary lifestyle that doesn't allow you exercise is going to make you more vulnerable to back pain. So this is a sitting position illustration. So this lady is not sitting well. Ideally, your chair should have a backrest that is between 90 and 110 degrees, not more. A chair that is reclining like this will be difficult for you to sit properly on, especially if you want to walk. Her leg is, the edge of the chair is impinging on the back of her knee. That affects the blood flow to her leg. So this is not good. Her foot should be on the ground. So her ankle is bent, her foot is not on the ground, and she's straining her neck because she's now trying to lean forward to compensate for the reclining chair so that she can walk. So this is not good. This is also not good. The chair is at a good angle right now, but her buttock is not touching the back of the chair, and her neck is also leaning forward. So that's not good. Something is impinging at the back of her knee. The chair is impinging at the back of her knee, and her foot is not touching the ground. These two are good positions. So it's good for the chair to have a small back support because the back is arched. So it's not a straight, it's not flat like a ruler. It's arched. So this small cushion here is supporting the back as it is. And her buttocks are against the chair. And the chair is not impinging on the back of her knee. Her feet are on the ground and her neck is being supported. So this is good position. This is also good, even though the chair does not have a cushion, but the chair itself has a small curve that is fitting the curve of her back. So those two are good positions. So this is bad. The neck is slouched forward. So this guy has a good chair, but he's not sitting properly. That's what I was talking about earlier, that you can have a good chair, but you're not sitting properly. So if he sits for prolonged period like this is not good. So his neck is leaned forward. That's going to put his neck under strain. Now you can see his spine there. So he's now using the chair properly. The chair has a back support that is supporting his back, and his knee, the knee should not be bent more than 90 degrees. Like that. Ideally, the edge of the table, and he has an armrest, sorry. Ideally, the edge of the table should be almost close to your tummy, such that you can write or type without having to lean forward. Yeah, so this is what it looks like. So your screen shouldn't be so low that you are having to strain your neck. So your screen can be raised a bit so that you can look at it without having to strain your neck. So shoulders are relaxed. He has a proper back support. The arms are supported. If your arms are hanging free, they tend to pull your shoulders and your neck down and strain your neck muscles. So the hands are supported. The thighs are horizontal and the feet are on the floor. So this is good. This is the wrong way to lift. If you're lifting like this, you're putting strain on your back. You need to squat and lift so that your back muscles are not being strained. I'll talk about back pain in pregnancy. Quite common, and I know a lot of our patients probably want to hear it. So it means your baby is growing. It's quite common to begin with.
Hello.
For many patients who are having back pain in pregnancy, they didn't actually have back pain before the pregnancy. So it just comes for the first time in pregnancy, and that is not uncommon. It can happen at any time in pregnancy, but usually starts from early pregnancy. The reason for back pain in early pregnancy is different from back pain in later pregnancy. If there was no back pain before pregnancy, most of the pregnancy-related back pain, which can be hormonal or positional, tend to disappear after the pregnancy. So don't despair, even if you're having back pain in pregnancy, it's not going to continue most of it. So why do they have that? There's a hormone called relaxin that the body releases early in pregnancy. It helps to relax the tissues and allow things to stretch. That's why your tummy can stretch to accommodate the baby. The uterus, which is usually the size of your fist, can grow to the size of a baby to accommodate the baby because the relaxin actually helps that. But it also relaxes some of the ligaments around the back and make them a bit more mobile, and movements can cause pain. Also, increasing weight adds to the pain because of the increasing weight that the pregnancy brings about. Then posture, the pregnancy, especially large tummies, tend to throw your center of gravity out of line, and you now are straining your back muscles to try and maintain an upright position. And over time, that actually tends to strain your back and cause pain. Muscle imbalance. The muscles of the front of the tummy are supposed to balance the muscles at the back. When the baby bump stretches these muscles at the front, they are not able to do any balancing act at all. And that can also lead to strain of the muscles at the back. Stress. We said earlier that psychological stress can cause back pain. So can manifest as back pain. So, and there's a lot of emotional stress that can be associated with pregnancy. So that can also be a cause of back pain. How do we minimize low back pain in pregnancy? Regular exercise helps. I know that some of this is not realistic. Maybe walking and stretching exercises. What probably would do, I think, I'm not sure if we do that in Cedarcrest, but what would help is sometime during the antenatal period, a physiotherapist might teach simple exercises you can do to maintain posture and to help the muscles of the back. That would help because some of these exercises are actually supposed to help the muscles of the back. Walking, swimming, stretching, etc. It also helps you not to gain too much weight in pregnancy. Posture control is important, especially because, like I said, the tummy tends to push the patient forward. Patient just strains the muscles of the back to try and maintain a posture instead of pulling themselves in to straighten their spine. So that can strain your back over time. So sit with support, with back support. When pregnant, sit with back support, support your feet. Don't lie on your back, especially when the baby bump becomes bigger. Apart from the fact that the pressure of the uterus can press on the big vessels and make you faint. is also the fact that the weight can strain your back. So lie on your side with the pillow in between your legs. That's what is advocated. Pull your shoulders and pelvis forward so that you maintain a good posture when you are walking. For many pregnant women, especially early in pregnancy, there are many drugs that we can't give. So we do encourage cold therapy, heat therapy. They can use ice packs, put on the backs for 20 minutes at a time, several times a day, or a few times a day. After a few days, you can switch to a hot water bottle, hopefully not too hot, wrap it around the towel so that it doesn't burn your skin, or you can put it on your back. Please don't put it on your tummy. That tends to help. Usually the relief is not very prolonged, but at least it tends to help from time to time, and it's quite soothing. For patients who have emotional stress, emotional trauma, counseling can help them in that situation. Then don't bend forward to pick up anything. Squat instead. I showed us the picture before. Before you choose acupuncture or chiropractic, which some people have found useful, please consult your obstetrician. Let them advise you before you decide to go into that. Don't take drugs on your own, especially more than paracetamol. Don't take on your own. You can take paracetamol for a short period. If the pain persists, please come to hospital. Like I said, there are many drugs that are not good for the baby. There might even be over-the-counter drugs or drugs you can get if you request. But especially if pharmacist does not even know that you're pregnant, it's something that is quite harmful for your baby. So don't take more paracetamol. That pain is persistent back pain when you're pregnant, especially if it is cramping. Please go to hospital. Cramping pain can be a sign of labor, and if it's preterm labor, you might not even think it because your womb will not change you. You won't have tummy pain, or you have pain in the back. So don't take it lightly. If you have cramping pain that is persisting, please go to hospital. Any back pain that started before pregnancy might be one of the other causes that I spoke about. So the doctor will probably refer you to an orthopedic surgeon who will assess you, and it will be treated on his own merit. So in conclusion, low back pain is quite common. It's commoner as we get older, unfortunately. Majority of patients don't have a serious problem. So back pain does not automatically mean that you have cancer or you have something serious. It can be managed successfully. It can also be prevented successfully. Thank you very much. I will pause for your questions.
All right. Thank you for that, Dr. Ikwe. So like I said, if you have questions, I've not yet seen any questions on the chat bar. So I'm wary of asking people to unmute their mics because then we might have too many people speaking at the same time. So please, if you have questions, type them in the sidebar, and I'll ask all who have not. When you're not speaking, please mute your mic. Thank you. So yes, we'll take questions now. Please type them in the side chart.
You can raise their hands too.
Yes, you can raise your hand in on the app.
Yeah? Yeah.
Okay, there are quite a few chats, but I'm not seeing any questions.
You can only read. Oh, gaskiya, I don't know what to do to either. Yeah, I hear them. Soon as connecting.
Okay. Mr. Akinwale Akinola, you have a question?
I want to ask question. I don't know what to do.
Yeah, good morning. Many thanks, Doctor, for the
presentation.
We'll appreciate if you can share the link afterwards.
Okay.
My quick question is this: what specific exercises can be done to reduce or reduce the possibility of having back pain, or in the event that one experiences back pain, to get rid of it.
Okay. Thank you very much for that question. Like I said earlier, when we have patients who have back pain, sometimes we just take them based on how they present. If the patient is in a lot of pain, that might not be the time to start asking them to exercise. But if they're in a lot of pain, you can actually ask them to rest. But subsequently, once the pain gets better, then there are exercises that can be done. For regular patients, you want to reduce or prevent back pain. Just remember not to lead a sedentary lifestyle and be active. I said you can cycle regularly or swim or take regular walks. Those things tend to make sure your back muscles don't get very lazy. And because that's back muscle. I don't want to go into the technical parts of it, but there are three elements of support of the back: the bones, the way the bones are arranged, the ligament, and then the muscles. The bones and the ligaments tend to get stuck once the disc begins to have a problem, and there's nothing you can do about them except you do surgery. But the muscles you can make the muscles stronger. You can bulk them up. So the muscles are like the last line of support. And if you allow the muscles to become weak, then that means that the back now doesn't have any support at all. The back becomes difficult to manage. But the physiotherapists can give specific exercises. There are specific exercises that they can give you that you would be able to prevent back pain or to have relief even when you're having back pain and the back pain is improving. What I can do, I can share a link to those exercises later. Maybe they can send them by mail to people who drop their email addresses. And so people can do it. Those ones are easy indoor exercises that you can do that can help to strengthen the muscles of the back specifically. But generally for healthy exercises, aerobic exercises, taking walks, swimming and cycling tend to be quite helpful. Somebody raising their hands.
All right, so what I'm going to do is I'll alternate between, there's those who have typed their questions and then there are those who are raising their hands. So I will alternate between the two. Okay, so we have a question from someone about the role of the orthopedic beds from Abdullahi Ibrahim.
Okay, that's good. Usually we tell people to use a firm mattress when they lie down, but that seems to be changing quite a bit. What the emphasis is on now is not that the mattress should be hard or orthopedic, as they say. The emphasis is that the mattress should not sink when you lie on it. It should not be a mattress that sinks in when you lie on it. So if it sinks and your back has to curve, that's not good mattress. Or the mattress is uneven, that's not good mattress. So the mattress can be a regular mattress as long as it does not sink in. So the role of the orthopedic mattress, the mattress that is as hard as a rock, is actually being taken away right now. So you don't have to spend so much money buying an orthopedic mattress, but make sure that your mattress is not so old that as you lie on it, it just sinks in at the middle. That's not good for your back.
All right, thank you for that. We'll take a question from Mr. Nuruddin Akindele. Please ask your question, sir. Mr. Nuruddin Akindele. Okay, we can go to the next person, Mr. Agusa. You still have a question?
Yeah, good morning. Good morning, everybody, please.
Morning, sir.
Yeah, the issue of backache seems to be, as you said, a progressive situation. As a medical practitioner myself, I want to inform you that when I first had backache, I visited my orthopedic surgeon and I was placed on some treatment. I graduated from those treatments into physiotherapy. But what I discovered is that as one continued to age, it became more, painful and intense. In the mornings, I'm okay, but after midday, the pain becomes so intense. One of my problems is that I cannot stand long. That's the greater, even when I was still practicing, I'm now retired. When I'm doing ward rounds, I can't stand, I have to sit most of the time. So my basic problem is, I do exercises also. The inability to stand for a long time is my greatest problem. Even as a Muslim, when I pray, I cannot stand long. So I just want to seek your advice on what you think one should do at this stage. Thank you very much.
Okay. Thank you very much, sir. At least you're a doctor, because usually uncomfortable with giving specific medical advice during webinars, because we emphasize that because we've not had the chance to examine you and all that, this is not advised to be taken as sacrosanct. But there are two possibilities that are coming to my mind. One is that you have facet joint osteoarthritis, osteoarthritis of the back. It's relieved when you bend forward, so like when you sit or squat, but when you stand, it tends to be worse. But if you can't stand long and the pain is not just in the back, the discomfort is in your legs, then that is most likely spinal stenosis and spinal claudication. And unfortunately, spinal stenosis does not listen to anything apart from surgery, because what happens is that the spinal canal, where the spinal cord is housed, is narrowed. So whatever is narrowing it is putting pressure on the spinal cord, and it tends to get worse. So if, for example, you could stand for like an hour before it became uncomfortable, after some time, when it progresses, you realize that you're only able to stand for 30 minutes. That's a progression of spinal claudication or spinal stenosis. And that's an indication that you do need to have an MRI and a proper spine surgeon check it out to see whether it's time to think of an intervention. The risk with leaving it to continue is that you might enter one of the red flag zones where we have what we call cauda equina, and it might begin to affect your ability to hold your urine or to pee or poo and all that. And that at that time it becomes urgent because that's the prelude to weakness, and weakness leads to paralysis. So like I said, if the pain is more in the back and your legs are fine, the discomfort is not in the legs at all, then it's most likely facet joint osteoarthritis. Most of the time, they can either improve by physiotherapy or specific intervention in the facet joint can improve them. But if the pain is not mainly in the back, but the discomfort is more in the legs, that's a sign that you have spinal stenosis. Spinal stenosis is something that usually responds to surgery. Most other modalities will just be temporary fix, but it will progress and you will need to have a decompression. So I will advise you to see a spine surgeon and have an MRI to ascertain what exactly is going on. Next question.
12.
All right, so there's quite a few typed questions. Can I go through a couple of them at the same time? All right. So the first is from Wendoa. She asked why it is more common in women, and just wanted to understand better what women in particular can do in their own case. Elsie asked if brisk walking helps. Anita wants to know if back pain is associated with chest or abdominal pain. And then the last one from George is we wanted to know if the long-term use of drugs is harmful. So I'll stop there and then we'll do the next batch of questions.
Okay, so the first one is why women? We don't know for sure, 100%, but there are a number of factors. One is repeated pregnancies. Like I said, if you've had problems with your posture during pregnancy, you can put cumulative strain on your back. It's almost like somebody who goes to the farm as well. So repeated pregnancies can cause a strain. For postmenopausal women, they tend to lose the strength of their bones faster because after menopause, balance of estrogen and progesterone, that's the hormones of the female body, there's a balance that is needed to maintain proper health of bones. It's connected to vitamin D in a complex way, vitamin D function in a complex way. So the health of the bone is maintained by the balance of estrogen and progesterone. After menopause, that balance is lost because estrogen level goes down significantly and progesterone is higher. So the women tend to lose more bone after menopause than men, even though men also lose strength of bone as they grow older, but women tend to lose it faster. So they become vulnerable to some of the factors like vertebral fracture, osteoporotic fracture as you grow older. So that's one other factor. Another factor may be hormonal, but we're not sure how that affects it. But yes, by a small degree, women tend to have low back pain more than men. The next question is brisk walking, whether it helps with the pain. No, brisk walking does not help with pain. Walking is encouraged as a form of exercise to keep the back muscles alive and healthy. That tends to be more preventive than anything else. Most of the time, if you see things like exercise, brisk walking, physiotherapy, we're actually doing it after the acute pain has gone. Physiotherapists have the way that they are able to control your pain. So even a patient with a very bad pain, if a very skilled physiotherapist can actually help them to feel better with the pain before they start doing stretching exercises later when the pain is better. So the aim of walking is not to control pain. The aim of walking is to help with the health of the back and the strength of the muscles. Somebody talked about that long-term use of drugs is harmful. Yes, they can be harmful, especially if you're using it in an unregulated manner. Most of the drugs that we use are called non-steroidal anti-inflammatory drugs, things like cataflam, ibuprofen, Voltaren, so a whole family of drugs. They're quite useful because they help with the pain, and patients can become dependent of them to the extent that they take them every day. They feel better when they take them. It looks like it's a short-term treatment, but those drugs have their own problems. Apart from the fact that they can aggravate ulcer in patients who are prone to ulcers, that can be controlled, but they can also cause problems with the heart in patients who have long-term heart problems. But the most important fear is that if you take them for too long, they can actually affect your kidneys. So we usually discourage taking them every day for too long. In fact, for my patients who have arthritis, knee arthritis and hip arthritis, they're asking me when they have to come in and do surgery. I say, when you have to take cataflam more than twice a week, then you know that you're actually putting your kidneys at risk. And it's better for you to come in and do a knee replacement and be free of pain rather than putting your kidneys at risk. Because when your kidneys pack up, even if you do a successful knee replacement, the kidneys are not going to come back. So that particular family of drugs can have its own effects. Some of the drugs we use can cause drowsiness, and we warn you that you shouldn't drive or operate heavy machinery if you're drowsy, things like Lyrica and muscle relaxants. So the drugs have their issues, and usually the doctors just try to juggle them on how to use them. I know that commonly in Nigeria, because we have a lot of access to drugs in the pharmacies in an unregulated manner, patients tend to abuse drugs. But like I said earlier, if your back pain is lasting for more than a month, you need to see a doctor, you need to see an orthopedic surgeon so that you know the best way to go about it. There's a fourth one I missed. I think your third question.
Yes, whether it's associated with chest or abdominal pain.
Not usually. But there's a kind of pain. When some patients have ulcer pain, they go to the middle of the back. And sometimes ulcer pain can present as middle back pain. So usually that's one of the things we check. But usually not as waist pain or low back pain. That tends to be the.
You've answered another question about ulcers then. Okay. It's just the next group of questions. So somebody wants to know if a slight pain on only one side, the right side, that's persisted for over 6 months is a cause for concern. Then they wanted to know, you talked about spinal injections, what the drug in the injection is. Someone wants to know if the DEXA machine is the same as the bone density test. And then what should a patient do if the injection doesn't work?
Okay. So the first one is slight back pain. It depends on what they mean by slight. If the pain is not bothering them, it's not increasing, and they're able to continue with their regular activities, it's probably a muscle ache. muscle related. Some of those pains will come and go. But if it's persistent, as in they have the pain every day, then it's probably safer to have anything more than 4 weeks checked out. Safer. You might check it out and the doctor says it's nothing. Then you're safer that way, rather than knowing that you've been incubating something for 6 months and you could have done something about it earlier, and now it's a bit late. So there's nothing to lose by going in for an orthopedic consult, doing an X-ray, and the doctor says, don't worry about it. You're safer that way than incubating something for a long time. What drugs do we use for spinal injections? Most of the time we use steroids. I personally use triamcinolone and dexamethasone, depending. If you're injecting, if you're injecting in the epidural space, you can use triamcinolone or other types of steroids, but they are mostly steroids because they have a long-term effect. Their effect can last for 6 months or more. So that's why we use them. Now, these steroids, can they cause general problems in the body? Not likely, because it's an injection that you give maybe once in 6 months at the best. Because if the effect lasts less than 6 months, then the next one is probably not going to be very useful. So most people will not repeat less than 6 months. But if it lasts,
Mommy, God bless you. Your son will survive.
Dr. Uka, you can mute him.
I can notice.
No, so I hope you sprayed air freshener. Yeah.
It's Obiora Azubike. Obiora Azubike. Please mute your mic.
Okay. Okay. Sorry, we're talking about. Sorry, Nyanang, I've lost my train of thought. What were we talking about?
So you just concluded what you were saying about
the steroid injections. Yes.
steroid injections, yeah.
DEXA scan is the same one used in the US. Yes, most likely. DEXA scans are probably just made by a few companies around the world. Ours is made by GE. GE is an American company, so it's most likely one of the big companies, Siemens or some of the big companies, but they work in the same principle. Yes, they check your bone density, which is probably something advisable after you are postmenopausal. But check the bone density to see, because there are things that we can do to stop the bone from getting soft too fast. There are things that can be done about that. And so if you check your bone density and it's becoming too soft, you can do something about it before it becomes a problem, because the bones begin to crack or something. So even as routine, they should be checked.
Now, so when you say mute, they will be hearing you.
Not the last question.
The last one was on after the injection. If it doesn't work, what should a person do next?
Usually the person will be assessed again. An injection that doesn't work, usually injections follow conservative management that has failed. So if the injection doesn't work, the patient will be assessed whether he's a candidate for surgery. So the patient should go back to the doctor and get another assessment.
Right. So there are two. We'll take back to back the two people who raised the next two people who have raised their hands, Mr. Agusa and a Madhu Patrick, a Dr. Madhu Patrick. So just state your questions very briefly, one after the other.
Okay. Good morning, everybody. Dr. Ekwe, thank you for a very educative and enlightening presentation. I have a very highly sedentary job where I have to sit from 9 to 5 every day in front of a system and only get to stand up when I remember I have to stand up. Also, I have a hobby of walking every day. I walk 10 kilometers every day, weekends and weekdays. So I'd like to find out if I can continue doing this for long-term, number of years, without any adverse effect on my spine or my lower back. Thank you.
Okay. Next.
Yes, Dr. Madhu Patrick, please go ahead with your question.
Okay, thank you for the opportunity. My question is twofold. First of all, under red flag signs, you spoke about weakness or heaviness of the legs. I wanted to ask if tingling sensation can be added to the list.
I know that's Zoom meeting.
Two is where you mentioned other prevention. Sorry. Two is where you mentioned other prevention, putting the foot on one block. I want to know exactly what that means. Thank you.
Okay.
Mr. Obera, please mute your mic.
Cataflam, all those things I know every time for too long is not good. Because you have been using those things for.
Okay. Okay, so I've successfully muted them. So a sedentary job, you have a sedentary job that you sit from 9 to 5. I hope you saw the pictures that I put up earlier about how to sit. So let me just put that.
Yes, I did.
Okay, you did. Yeah, so it's important that you sit properly. You have a good chair and you sit properly. It's important. That one of the problems with sitting properly is that sometimes you just go back to what you're used to and you slouch and all that until you remember to sit. So one is having a good chair. Two is remembering to sit properly, consistently as possible. Three is remembering to stand up and walk around for 5 minutes, maybe every 2 hours or so. That also refreshes your mind and all that. So it doesn't actually reduce the efficiency of your work. If anything, it increases it. If you walk 10 kilometers a day, I'm actually impressed. I wish I could be like you. So that probably balances for your sedentary lifestyle. But the effect of sitting 9 to 5 is major if you're not sitting properly. So I think you should try as much as possible to modify as much as you can during work, and maintaining a good walking habit of exercising daily is very good. Actually, I encourage you to do that as long as your knees are not acting up or giving way, and exercise is good. So I think you can continue to exercise. Just make sure that you try to maintain a discipline of sitting properly at work. The second question said whether tingling sensations are a red flag sign. No, usually not. The reason being that tingling sensations are probably the first set of signs that you get when a nerve is being compressed. So if it's just on one side, on one leg, that's like the beginning of a radiculopathy. So you can have tingling sensation before you even have pain. So tingling sensation is still an early sign. It's not the red flag sign. It's not considered to be a red flag sign, but it's an early sign that you may be having sciatica or nerve compression. When I talked about your standing posture, so if you stand, the way your spine is erect. When you put your leg forward, that tends to relax the sciatic nerve a bit, and it's thought to be better if you keep changing positions than for you to just maintain one position for a prolonged period. So it's just a way of making sure that you're moving around and you're not stretching your nerve as much as possible. All right.
So the next group of questions. Okay, so I don't have a name, it's just the person's phone. What advice do you have for somebody who is a child with low back pain and no history of trauma? Dapa asks, do shoes affect your back pain? Nora wants, okay, no, we've answered about ulcers and low back pain. Dorothy wants to know about what proper sleeping postures are and what kind of mattress you recommend. And then lastly, Justin wants to know if there's any kind of medical regulation on the type of office chairs that are used.
Okay, so the topic of children and low back pain is actually a whole different topic, and there are many things that were different. I thought it would be too much to add to this presentation. But children can have other reasons for back pain. Some of them are even congenital. Maybe there's something wrong with the vertebra, what we call hemivertebra, absent vertebra. Some children have scoliosis, the spine is bent, and back pain in that context would be something completely different. Ideally, children within the first 10, 15 years should not be having back pain without any sort of trauma. So it's better to actually bring them in and have them checked out. It may be something serious, it may not be. There are other things called Schaumann syndrome. Children also growing up can slouch a lot, have poor posture, and that may just be the reason for the back pain. So those ones will do well with physiotherapy and all that. But back pain in children is a wide topic, so I didn't want to include it here. But generally speaking, as a form of advice, if a child has persistent back pain, it should be checked out. It's not supposed to. Children are not supposed to have persistent back pain. They can have back pain from maybe a strain or something, that they played football and they stretched their muscle, but that shouldn't last for too long. Even back pain is persisting for a child, it should be checked out. It's not normal. Shoes. Actually, I missed that out, especially with pregnant women when we were talking. It's said that a shoe with a low heel and arch support is actually better than a flat shoe for the back. Low heel and arch support. Now, I know that I usually fight with my female patients when we're talking of low heel. They'll bring something that looks almost 6 inches and they say it's low. I tell them, no, this is not low, at least not for an orthopedic surgeon. So probably low heel shouldn't be more than 2 inches, preferably an inch. That's 2.5 centimeters off the floor. But anything more than 5 centimeters off the floor cannot be low heel. Significantly high-heeled shoes are not good for your back. Because what happens is that the shoes tend to throw your center of gravity forward, and you have to stretch your back muscles to accommodate them. So to a certain extent, it's doing almost the same thing that the pregnancy is doing, just doing it from the opposite side. So if you have back pain, you probably should reduce your heels. And the advice is not to go to completely flat, but low heels with an arch support for the foot. There are shoes that don't have an arch support. An arch support is something a bit cushy on the medial side of the foot, on the inside of the foot, that helps to support you when you walk. Especially if you have something like key legs or things like that, you need an arch support to make you comfortable. But very flat shoes, no. But flat shoes are better than 6-inch heels. Those 6-inch heels will throw your center of gravity out of line. Sleeping postures, any position that you're comfortable with is fine. If you're pregnant, sleep on your side. That's what's the what's the last one? Medical something? Sorry,
whether there's any kind of medical regulation or recommendation on the type of office chairs to use.
Well, there's no regulation. If you call it regulation, that's like a law or something that the government has advised. I don't think our medical system is that sophisticated. I'm not even aware if that happens. But what has happened is that for some organizations, I know that for some of the oil companies that we've worked with, they have made ergonomic chairs the part of office work because they know that people sit for prolonged periods. They've had people have to leave the back room for long periods, and many people just leave the office or their back is painful and all that. So they've just changed all their chairs to ergonomic chairs. And an ergonomic chair doesn't have to be expensive. We're back to this again. The principles are that it will have a small arch support for the back. It will have a backrest. Sometimes if you have the neck rest, that's not bad, but it will have a backrest. And if the chair can roll, it's better, but you should have an armrest as well. When you juxtapose it to your workstation, the arms should be able to enter under your workstation such that the edge of the chair can be against your tummy and you can type and write without having to slouch forward. So two things go hand in hand. And the way you use it. I emphasize this way you use it a lot because I've seen a lot of people with proper chairs, expensively bought chairs. There are some people that have imported chairs from abroad. And that also that's like not doing any work actually, because you have a chair, but you're not using it properly. It's better you have a small plastic chair that you put a small throw pillow at the back and you're using it properly. That you have an expensive chair and you're not using it properly.
Right, thank you. Please, Mr. Alonso Onwanide, please mute your mic. Dr. Gray, you can also mute them. Okay. Next set of questions.
I'm listening. Hello?
Yes, sorry, can you hear me?
I can hear you now.
Okay, good. So I was saying the next set of questions is whether anesthesia can cause back pain. That's one. Two, can the way we cross our legs affect our back pain? The next one is a very technical question. Somebody diagnosed with lumbar spondylosis with mild intervertebral disc herniation and foraminal compromise at L5S1. Would such a person require surgery? And then lastly, for this batch, are antioxidants useful in the management of low back pain that is due to chronic osteoarthritis? Is that?
Okay. Can anesthesia cause back pain? The truth of the matter is that so many patients who claim that after an epidural anesthesia, they have back pain, that people are beginning to take a closer look at it to see if it causes. Conventional wisdom says it does not. We do not have enough medical evidence so far to say that a well-done epidural will cause back pain. But then when you have lots of patients telling you that they have back pain after anesthesia, I think it's something that people are beginning to take a look at again. I was talking to my anesthesia colleagues, anesthetist colleagues the other day, and they were saying that quite a few patients are complaining about back pain after epidural. It's not that common, to be honest, maybe like 5% or less than that. But then that's a lot, because a lot of people go through epidural anesthesia as it is, because it's one of our favorite ways of giving anesthesia. It's quite useful. You're talking to the patient, you're comfortable with the patient, and the patient's pain is controlled even after surgery. So I guess the answer is we may need to wait and see. Let this new set of research come out. So far, the evidence suggests that it does not. Crossing legs, if your back is well supported, it's not a problem. The problem is that many times when you're crossing legs, your back is actually not resting against the chair, the backrest of the chair, and you're slouching. So if you spend long periods in that position, that may not work in your favor. Remember that it's the consistency of the risk that leads to whatever effect. For example, if I smoke one stick of cigarettes once a week, as a contribution to back pain, that may not be as significant as somebody who smokes 2 packs a day even for the same period that I smoke. So is that being consistent with the risk? Somebody who sits and drives for long hours going to Lagos, but that's not his job, might have back pain and back strain, but it's not the same risk as somebody who is a driver, long distance driver, and is always taking that particular road and is not actually watching his back properly when he's driving. So it's the consistency of the risk. If you cross your leg once in a while, that's not going to be a problem. But remember that, like I said, when you cross your legs consistently and your back tends to be slouched, that can be a problem. Like I said earlier, for the technical question, we try not to use this as a consultation forum, because not having had the opportunity of taking a history and examining and assessing you, I could give you a wrong advice. But generally speaking, So don't take this as a medical opinion, but I'm just trying to answer the question for general knowledge. Generally speaking, what you have, lumbar spondylosis, is the wear and tear that we talked about earlier, and it's usually age-related. Intervertebral disc herniation means the disc is being pushed out of space, and it can put some pressure on the spinal cord or some pressure on the nerve that's coming out of the spinal cord. So when it puts some pressure on the nerve coming out of the spinal cord, that's what we refer to as foraminal stenosis. So it can cause spinal stenosis, can cause foraminal stenosis. So two things decide on what the surgeon does. One is the amount of symptoms that the patient is having. Two is how bad the MRI looks. So if the MRI looks terrible and the patient says, look, I'm fine, don't worry about me, then the doctor will just probably be saying, okay, let's watch and see, let's observe. If the MRI looks good and patient says, that's a problem that needs to be sorted.
If you don't cross, you sorry.
Please, Mr. Sanson, mute your mic.
Pakistan.
Okay, I've muted everybody. So if a patient is in a lot of pain, terrible pain, and the MRI looks good, you might want to just assess the patient again. But if both things are suggesting that the patient is not doing well, then that patient might benefit from decompression, because that will be the dramatic improvement in the pain. So if a person's pain is, say, 4/10, 3/10, then you might say, look, let's watch you and see. If your patient's pain is 9/10 or 10/10 and says, look, I can't do anything. I can't go to work, I can't sleep, I can't do anything, then that patient might be a candidate for surgery. So there are many things that determine what you do. Antioxidants are better for prevention, even as a principle. Antioxidants are better for prevention. They don't actually cure, as far as I know. I know that in osteoarthritis of the knees, they don't do much. So we can give a lot of them as supplements, but patients still end up having a knee replacement or having a lot of knee pain if the arthritis is established. So for a patient who already has an established degenerative disease or a progressive disease of the spine, antioxidants will not change the course of the disease. I think I've answered all of that. Yana, are there any other questions?
Yes, a couple more. Okay, so Fabiola would like to know what kind of specialist to see to address an adjustment in lumbar/hip problems. So she wants to know whether to see a chiropractor, an osteopath, or a physiotherapist. And then Laura would like to know what kind of exercises are recommended after someone has had a spine injection. And then Mr. Patrick wants to find out why there is early morning waist pain and it subsides afterwards, and is that something to be concerned about? And then finally, what would be the cause of having foot heating and you won't feel it when you're walking around, but when you stay in place? So I don't know if it's the feeling of pins and needles after sitting in a stiff position that he's talking about. And then Dr. Mello wanted to emphasize the need to have your car seats in the correct position as well.
Okay, yes, that's true. Especially in our modern society, we tend to spend a lot of time in cars, especially if you are coming from hold-up areas. You'll be surprised how much you spend in traffic and just sitting in cars. So sitting properly in the car is also important. Adjusting your car seat so that you're not slouching forward, and putting a backrest, making sure you use the backrest of your car is important. trying to get the questions from beginning. You said something about hip adjust. I'm not sure what that is.
I'm not sure either, but it's some kind of to adjust hip/lumbar. So whether to see a chiropractor, an osteopath, or a physiotherapist.
Well, like I said earlier, the correct course, the correct sequence of care is that if you have a problem, you go to a doctor first. That's the correct sequence. So you go to the doctor makes a diagnosis and decides whether he wants a physiotherapist to look at you and involved. And for majority of back pain patients, physiotherapy is our way out for a start. Physiotherapy and drugs and all other things that form conservative management would help for majority of patients. More than 80% of patients will do well with conservative management. There's only a few patients who don't do well that will go on to have other kinds of treatment. Because we try as much as possible not to do an invasive treatment unless we don't have a choice. So if you see the doctor will say, okay, you do this. Now, most of us regular doctors or orthopedic surgeons are trained with normal medical practice. Let me not say normal, routine medical practice. For things that are alternative medical practice like acupuncture and chiropractic, these are not things that most of us are trained with. And you will not find many doctors who are very familiar with the processes that they do. I know that chiropractors do some manipulations that tend to help, even for pregnant women. That's actually is one of the things that people have suggested that you can use. For pregnant women, sometimes we're a bit more desperate because we don't have many drug options. But these are not routine medical practitioners, so to speak. And it's not common to see a doctor referring you for acupuncture or physiotherapy, but it does happen. I know when we visited, some of the hospitals in Tunisia, they actually had acupuncture departments in the hospitals, in the government hospitals. They had departments that dealt with acupuncture, usually rheumatology departments. So they probably tried to incorporate it, but it's not something that we're quite familiar with. And I would suggest that even before you see that person, at least see a doctor first to make sure that your diagnosis is something that they can treat. There are some things that they can't treat. To be honest, if you have an infection or cancer or something, then you're wasting time if you're going there. And every time spent can be important. What exercises are recommended for one who had the injection of the spine? And what's the aftermath of injection? The same things that we've been saying. There are no different exercise regimens for people who have had an injection. It's just, if you've had back pain, it's even more important for you to take care of your back. That's it. It's even more important. But even for patients who have not had any back pain at all, trying to make sure that you're not getting your back muscles to become weak is an important thing so that you don't develop it. So it's like what you do to prevent it is the same thing you do while you're taking care of it. Even for patients who have had surgery, they are expected to actually not make their backs lazy. So maybe you take walks, swim and all that. So it's the same general things that we've spoken about. There's nothing special about that. Somebody has two questions. What is the reason for you to experience pain when you wake up from bed and after a while to subside? That can happen. It's one of the things that happen because of a change of posture, especially early in the disease process. After some time, it becomes more consistent or persistent. Foot hitting when you feel it when you are walking around, but when you stay in a place, it becomes better. I guess that's what he's trying to say. So if a patient has pain, has what we call a paresthesia or radiculopathy. Radiculopathy can manifest as pain, in which case you are feeling pain down the leg, but it can also manifest as other signs because there are other things that the nerve also supplies. Heat and cold feeling sensation is one of them. Tingling sensations can happen. You can feel like the leg is not yours, like a dead leg. All those are things that can be coming from the spine, but pain is the commonest. But yes, you can have feeling of heat or cold in the same leg, and it's also thought to be part of radiculopathy. Okay, any other questions? We should be rounding.
So we're rounding up now. I'll take one last question, and then we'll round up here today. What do you have any other brands of chairs that you recommend? And then what is the proper height ratio of your table to your chair? How high, I guess that's, how high should your table be from your chair?
Is that all?
Yeah, that's the last question we're taking.
Okay. There's a suggestion of inches here, 25 to 30 if you're looking at the screen, to 30. But the truth of the matter is that I've tried to make the recommendation in general because there are very many chairs. I don't even know the brands. I don't know the names of the brands. But the important things are important. The important things are that your chair should be comfortable. It should have a small, your back is not straight, your back is curved. You can see the curvature of the spine. Back is not curved. So there should be a small support that supports the back. So it could be an extra cushion. It could be a throw pillow that you use for that. Or it could be that the chair is just curved. Like one of the chairs we saw earlier, the chair is just curved. I think, yes. Not this one. Yeah, like this. So in this one, the chair has a small support, like this one. And in this one, the chair is curved. In this one, the chair is curved. So that's important. Then the other thing that is important is that the chair should not be so executive. Sometimes the chair is so bogus, the arms are so big, and the chair is so fine that the chair cannot slide next to the workstation or under the workstation. And if the chair cannot slide under the workstation, then your table edge cannot be close to your tummy. And so if you have to type, it's either you make yourself uncomfortable or you slouch forward or you lean forward. That's not good. So the chair should be able to enter under the workstation. If you look at some of the ergonomic chairs, the armrest is adjustable. So you can make the armrest a bit higher or you can make it lower so that it slips under the work table so that you can sit close to your table and be able to type comfortably without lifting your back from your support. And then the edge of a chair should not be impinging on your knees because sometimes somebody is using a high chair and the person is not very tall. And then you realize that the legs are not touching the ground. That's not good. So you can't say a particular height because people are of different heights. But the principles are what I'm trying to emphasize so that whatever it is that arrangement you're making for your chair, you will be able to say, oh, okay, fine. These are the principles. My chair should be able to sleep under my work table. It should have an armrest, back support, should be comfortable for me to sit. If it has a neck support, great. And when I'm sitting on it, the edge of the chair should not be impinging on my knees and my feet should be on the ground. Those are the things that are important in choosing a chair. So you go to the market, you see, I actually saw somebody who bought a chair for 550 euros that he imported into Nigeria to use for his work. And he still came to meet me. So it's not the cost of the chair. It's not even the type per se. It's whether the chair is meeting the specifications and then how well you're using it. No matter how expensive the chair is, no matter how good the chair is, if you're not using it properly, you can still put your back at risk. It's as good as somebody not using a proper chair.
Okay. Well, somebody posted a far more detailed and I think very personal type of question. This came from a Mr. Nonso. But we've run out of time now. Dr. Eko, I don't know if you want to take a stab at that question or you want to respond to the person separately. It just typed it in the chat like 3 minutes ago about having on why Nibane also.
10 years, right?
Yes. But we're sort of out of time, so I don't know how quickly you can respond to that.
Okay. There are 1 or 2 lessons here. Let me read out the question so that at least people will just get the lesson. So I've been having lower back pain for over 10 years. it started from my right lower back, now is on my left lower back. And sometimes the pain is so severe, it's as if I'm carrying a very heavy object and I can't bend to wash my car. I've had 2 MRI scans and I was told that my spine is resting on the nerve. That's why I feel the pain. Please, how can I solve this? Oh, okay. Sorry, I thought she said he was carrying a heavy object. So I wanted to just emphasize that you can't do heavy lifting while your back is having problems. You shouldn't even do heavy lifting, generally speaking. And if you're going to carry anything more than 10 kg, it's very important that you don't bend your back and put the pressure on your back. Try and squat. Even if you're picking a pen, you should try and squat, especially as you grow older. For this patient, it seems like he needs some help. One will need to look at him. If he can come in, if you can come in, sir, and you have an assessment, one of our spine surgeons will look at you and we'll see whether an injection can help you. Because radiculopathy is one of the things that injection really works well for, or if he needs a decompression. But he needs to be assessed. Thank you.
Okay. Thank you very, very much, Dr. Ekwe, for this wonderful presentation. Thank you, everyone, for joining us, for taking time out of your day to be with us. We really appreciate it here at Cedarcrest. Please, if you'd like to receive the presentation and the exercise and posture slides, please, we've posted a link there. It's a short Google form. Some of you already have your email addresses, but not everyone who is here has sent me their email. So please click on the form there, on the link in the group chat, and fill that form. And we can message that to you, message the presentation and the other information about the exercises. Thank you so much again for your time. I don't know if any of the Cedarcrest management would like to say something before we close.
Well, like I said earlier, this is our first webinar, and we intend to be doing it at least once a month. And we will take on different areas where we think that we are leaders, medical leaders at, and our patients will benefit. I've already emphasized that it's not meant to be a consultation, so don't take it and run with it. But for patient education, also for you to educate others who might have the same issues, we'll try and make it as broad as possible to reflect the different kind of things that we do, that we think that we do well and enough. So we hope that it will become something that will be regular, and patients will experience Cedarcrest more without necessarily having to come to see us. We hope to actually make it better. Thank you.
Thank you.
All right.
Thank you very much. Thank you.
So if you'll be interested in more things like this, please, you can let me know. You can let us know via any of the channels through which you were communicated to, or even here. So please, if you're interested in more things like this, please let us know. Thank you again for your time. And fill the form if you'd like the presentation to be sent to you, and have a very good weekend.
Thank you, you too. Thank you.
Thank you very much.
Thank you.
Thanks, Ghana.
Thank you very much. I appreciate it.